Blepharoplasty is a type of surgery that removes excess skin from the eyelids. It is an operation in which redundant tissue, including skin and muscle, are excised from the eyelid, and sometimes fat may be excised and reposited. The appearance of the eyelids and periorbital region plays a pivotal role in the maintaining facial harmony through expression of human character, mood, and emotions. And a successful outcome from this surgery requires great attention in detail. Blepharoplasty is commonly two types: functional blepharoplasty and cosmetic or aesthetic blepharoplasty. A functional blepharoplasty aims to restore normal function and appearance to an eyelid that has been altered by trauma, infection, inflammation, degeneration, neoplasia, or developmental anomaly. While cosmetic or aesthetic blepharoplasty aims to improve the appearance of eyelid tissue that are histologically and functionally normal. Patient may present with tired look, hooding of upper eyelid, drooping of upper eyelids, eye bags, skin wrinkling, skin folds, a visual field defect, headaches, irritation of the upper eyelids, and lower lid dark circles. These are the common indication of for blepharoplasty. Female patients often complain of inability to place makeup on the upper eyelid. Applied anatomy. The upper eyelids. The palpebral aperture is almond shaped with lateral canthal angle lying slightly higher than the medial canthal angle. The lateral canthal angle is generally slightly higher in females than the males and lies approximately 5 mm from the lateral orbital margin. The upper eyelid skin crease is usually approximately 5 to 6 mm above the lash line in males and 7 to 8 mm in females. You can see in this picture. The distance between the inferior aspect of the eyebrow and upper lid skin crease on downward gaze should be approximately two-thirds of the distance from the inferior aspect of the eyebrow to the eyelid margin. Likewise, the distance from the skin crease to the eyelid margin in downward gaze should be one-third of the distance from the inferior aspect of the eyebrow to the eyelid margin. In general, a minimum distance of 10 to 12 mm should be left between the inferior aspect of the eyebrow and the upper eyelid skin excision marking when performing an upper lid blepharoplasty, and again in general approximately 20 mm of skin should be left between the inferior aspect of the eyebrow and eyelid margin. It is important to maintain these dimensions. If an excessive amount of the upper eyelid skin is removed, reducing the distance from the skin crease to eyebrow in the presence of brotosis, an unsatisfactory result will occur, with the appearance of the brow being attached to the eyelashes. This may also cause lag of ophthalmos. So, it is important to maintain these dimensions because these dimensions are necessary for proper closure and opening of the eye. It is important to differentiate prolapsed pre-aponeurotic fat from retroorbicularis oculi fat. That is roof you can see in this picture. That is retroorbicularis oculi fat, that is anterior to the periosteum of the frontal bone. This may give rise to the appearance of the upper eyelid fullness, although this descended fat can be debulked, but it is preferable to reposition it as a part of the brow lift procedure. Some patients have very prominent supralateral bony margins like this picture that can also contribute to upper eyelid fullness. This can be exposed by supraorbital incision and reduced with the use of burr during course of upper eyelid blepharoplasty. It is important to recognize a prolapsed lacrimal gland like this picture that may be responsible for lateral upper eyelid fullness or swelling. Prolapsed gland can be repositioned during the course of upper eyelid blepharoplasty by suturing the gland to the periorbita of the lacrimal gland into the lacrimal gland fossa. Some patients develop orbital fat atrophy, which creates an upper eyelid sulcus defect. The removal of preaponeurotic fat in such patients should be avoided to prevent a postoperative cadaveric appearance of the patient. A prolapsed medial fat pad in such patient can be debulked and the fat transplanted to lie evenly in the preaponeurotic space. So you have to transplant fat in this preaponeurotic space. In general, the removal of fat from the upper eyelid should be avoided in the majority of the patient during upper eyelid blepharoplasty. Fullness in medial aspect of upper eyelid may be caused by medial eyebrow ptosis. Elevation of the brow or the use of botulinum toxin injection in the glabella can be more successful for addressing this problem. Incision in this area can leave unsatisfactory scarring. It is important to avoid the temptation to change a dog ear into the area around the medial limit of skin crease during an upper eyelid blepharoplasty, as subsequent scarring can be very unsatisfactory. In such patient, a gentle debulking of the medial fat pad can allow the skin to redrape with or more satisfactory aesthetic result. But over resection of fat should be avoided. The fat should not be discarded as it may be required for reuse in the central aspect of the upper lid or maybe use of help to create a medial tear trough defect in the lower eyelid. There are two main fat pads in upper eyelid, a central fat pad and a nasal pad. The nasal fat pad is generally paler. It is extremely important to be able to distinguish the lacrimal gland from orbital fat. The levator muscle gives rise to the elevator aponeurosis at the level of Whitnell's ligament. The aponeurosis insert onto the anterior surface of superior two-thirds of the tarsus. The medial and lateral horns of aponeurosis insert in the region of medial and lateral canthal tendons. The lateral horns divide the lacrimal gland to orbital and palpebral lobes. Intraoperative damage to the medial horn can give rise to the lateral shift of the tarsus with an eyelid peak lying temporal to the pupil. Whitnell's ligaments support the elevator muscle complex, acting as fulcrum of the action of levator muscle and should not be disturbed during surgery. It is variably developed structure that runs from lacrimal gland to the region of trochlea. So this Whitnell's ligament is important to support the levator muscle. So it should not be violated during blepharoplasty. The lower eyelid can be considered to consist of three lamellae. First lamellae, that is anterior lamellae, is made up of skin and orbicularis oculi muscle. Second lamellae is middle lamellae, that is made up of orbital septum and inferior eyelid retractors. And third lamellae are posterior lamellae, which is formed by the tarsus and conjunctiva. The lower eyelid crease is variable but usually situated approximately 4 to 5 mm below the eyelid margin. The lateral canthal angle normally sits approximately 1 mm higher than the medial canthal angle. The orbicularis oculi muscle is immediately deep to the skin of the lower eyelid. This muscle extends from just below the ciliary margin, past the inferior orbital rim, and onto the cheek. Ptosis of orbicularis oculi muscle commonly occurs over time and is responsible for typical appearance of the malar crescent or malar mound in the aged face, like this picture. And there is, you can see, typical appearance of tear trough. Deep to orbicularis oculi muscle lies the orbital septum, which serve to retain orbital fat within the orbit. The septum is composed of inelastic fiber tissue. Atrophy of the septum with age permits orbital fat to herniate entirely, creating typical lower lid bags. The suborbicularis fascia, a plane of loose fibrous connective tissue, lies between the orbicularis and orbital septum and provide a very good, relatively bloodless dissection plane. The orbital septum extends from the inferior border of tarsus to fuse inferiorly with the periosteum of infraorbital margin. This inferior attachment of orbital septum to the periosteum where there is condensation of tissue, this condensation of tissue is called arcus marginalis. The arcus marginalis is strongest and best defined medially, where it attaches to the anterior lacrimal crest. As it extends laterally, it thins and weakens. It also assumes a more inferior and anterior insertion. Thus, medially, it is runs along the inner aspect of rim, but laterally it attaches approximately 2 mm inferior to the rim on the facial aspect of zygomatic bone. The tarsus in the lower eyelid is approximately 4 to 5 mm in the height. The lower eyelid retractor are analogous to the levator aponeurosis in the upper eyelid. The smooth inferior tarsal muscle is analogous to molar muscle in the upper eyelid. The lower eyelid retractors, collectively known as capsulopalpebral fascia, run along the inferior rectus muscle and spilt into envelope the inferior oblique muscle. This fascia then insert into the inferior border of the tarsus. A deep layer of the fascia attaches to the conjunctival fornix as suspensory ligament of the fornix. Isolated shortening of the anterior lamina of the lower eyelid result in ectropion. Of middle lamina result in eyelid retraction with scleral show, and of posterior lamina result in entropion. So, anterolamellar shortening lead to the ectropion, middle lamella result in retraction with scleral show, and posterior lamella result in entropion. There are three fat compartments in lower eyelid: medial compartment of fat, central compartment of fat, and lateral compartment of the fat. Many delicate fibrous septa invest these compartments. The fat compartments lies between the capsulopalpebral fascia and orbital septum. As capsulopalpebral fascia, also called lower lid retractor, is analogous to levator aponeurosis in upper eyelid, the fat lying in front of capsulopalpebral fascia can be considered to be analogous to pre-aponeurotic fat in the upper eyelid. As in upper eyelid, locating this fat is key to locating the eyelid retractor, as same principle apply there to locate the lower eyelid retractor. The inferior oblique muscle originating from the intermedial orbital wall lies between and separate the medial and central fat compartments as it extends posterolaterally under the globe. The arcuate expansion and extension of facial sheath of inferior oblique continues laterally to attach to the lateral orbital margin and separate the central fat compartment from the lateral fat compartments. Subtle difference exists among three orbital fat pads. The fat of the medial compartment is typically white and membranous, while that of central and lateral compartments appear yellow and soft. Lateral fat compartment contains more septa than the medial and central compartments and is therefore less prone to herniate anteriorly. It is important to note that inferior palpebral vessels travels directly through the medial fat compartment. Below the inferior orbital margin, posterior to orbicularis oculi muscle and just anterior to the periosteum is the suborbicularis oculi fat pad. You can see in this picture that is SOOF, that is suborbicularis oculi fat. With increasing age, the orbicularis oculi muscle and the suborbicularis oculi fat move inferiorly, leading to double convexity of the lower eyelid. The superior convexity is caused by herniation of orbital fat through a weakened orbital septum above the inferior orbital margin. The orbital margin itself is responsible for horizontal concavity, and the suborbicularis oculi fat, which moves inferiorly, is responsible for the second convexity. Like this picture, you can see also this ibex. Dermatochalasis describe a common physiological condition seen clinically as sagging of upper eyelid skin, as seen in this picture. It is typically bilateral and most often seen in patients over 50 years of age, but it may occur in some younger adults. Examination of these patient eyelid reveal redundant lax skin and poor adhesion of underlying orbicularis oculi muscle. An excess fold of skin in upper eyelid is characteristic, which obscure the normal upper eyelid skin crease, which may be lost. So in these cases, upper eyelid skin crease is not properly seen. This patient complained of visual field limitation and headaches towards the evening due to frontalis muscle fatigue, because they have to work for opening of eye. That's why there is fatigue of the frontalis muscle that lead to the headache. The tissue changes seen in dermatochalasis are similar to the normal aging changes of the skin seen elsewhere in the body. There is a thinning of epidermal tissue with loss of elastin, resulting laxity, redundancy, and hypertrophy of the skin. The tissue changes of dermatochalasis appear to be due to repeated facial expression combined with effect of gravity over many years. A number of syndrome disorders such as thyroid eye disease, Ehlers-Danlos syndrome, cutis laxa, renal failure, amyloidosis may hasten the development of dermatochalasis. In addition, some patients may have a genetic predisposition toward the development of dermatochalasis at younger age. So these type of patient may corrected with the blepharoplasty surgery. Dermatochalasis is often confused with blepharochalasis, although these disorders are quite different in both their presentation and their etiology. Blepharochalasis is a rare inflammatory condition that typically affects only the upper eyelids and may be unilateral or bilateral. It occurs often in younger patient. The condition is characterized by exacerbation and remission of upper eyelid edema, which result in stretching and subsequent atrophy of eyelid tissue. The secondary effects of blepharochalasis include conjunctival hyperemia, chemosis, entropion, ectropion, blepharoptosis, medial fat pad atrophy, and thinning of eyelid skin. Blepharochalasis stems for recurrent bouts of painless eyelid swelling, each instance of which may persist for several days. The swelling most likely represent a form of localized angioedema, although this remains speculative. Ultimately, after numerous disorders, the skin of lid becomes thin, atrophy, and damage of the levator aponeurosis muscle. Blepharoptosis then develop and blepharochalasis is idiopathic in most cases, although it has been linked for kidney agenesis, vertebral abnormalities, and congenital heart defect in the rare instances. The goals of upper eyelid blepharoplasty are to remove an appropriate amount of excess upper eyelid skin alone or skin and orbicularis muscle in order to achieve the best cosmetic and functional result of the patient. To remove and sculpt the herniated orbital fat only where appropriate. To create a symmetrical upper eyelid crease for appropriate height for individual patient. To avoid visible scarring. To avoid a secondary leg of thalamus or incomplete blink. And to avoid exacerbating an associated brotosis. So these are the goal of upper eyelid blepharoplasty. Surgical technique. The skin incision is made along the Jensen violet marking with a Colorado needle. A skin flap is developed and dissected of the underlying orbicularis oculi muscle. A strip of orbicularis muscle can be dissected off by underlying orbital septum. A patient merely required the removal of excess skin and any orbicularis muscle for functional reason. The skin can be closed with simple interrupted 70 or 60 bilateral suture. You can see this marking. The surgical procedure is quick and relatively simple to perform and does not expose the patient to a small risk of postoperative intraorbital hemorrhage. If fat need to be removed, fat should be carefully clamped using a small artery clip, and artery clip should be held carefully by the assistants. Great care should be taken to avoid anti-traction on the fat that can lead to rupture of the posterior orbital vessel and slight threatening retrobulbar hematoma. At last, the skin is closed with interrupted 70 or 60 bilateral suture, taking bites of very edge of the skin. The goals of lower eyelid blepharoplasty are to remove an appropriate amount of excess lower eyelid skin and muscle, to remove or reposition herniated fat where appropriate, to avoid middle lamellar scarring and eyelid retraction, to address any associated lower eyelid or lateral canthal tendon, and to avoid any postoperative ectropion or secondary epiphora. Surgical technique. A lower eyelid blepharoplasty procedure should ideally be tailored to the individual requirement of the patient. The surgical approach selected depends on preoperative assessment of fat herniation, degree of skeletonization of inferior orbital margin, the presence of lower lid convexity, the amount of excess lower eyelid skin, the degree of static wrinkling in actinic damage, the degree of orbicularis oculi muscle ptosis, the presence and degree of midface ptosis, midface fat atrophy, the presence of malar molds and festoon, and degree of lower eyelids and lateral canthal tendon laxity. These procedures can be performed with conjunction with orbital decompression by transcutaneous or transconjunctival approach. Surgical management mainly by two approaches: transcutaneous lower lid blepharoplasty and transconjunctival lower lid blepharoplasty. These procedures can be supplemented by other techniques to enhance the result, like horizontal eyelid tightening procedure, pinch technique, skin resection, CO2 laser resurfacing, TCA peel, botulinum toxin injection, injection of dermal fillers, mid-face lift, and placement of cheek implant. These can be combined with this blepharoplasty. Transconjunctival approach is preferred for patients with fat herniation, but there is no excess skin. This approach avoids an external scar and also ideal for patients who have previously gone through transcutaneous blepharoplasty. It can combine with CO2 laser resurfacing and T-shape peel. for the skin wrinkling, and these patients required about sun exposure postoperatively. Transcutaneous blepharoplasty with fat debulking. For the majority of patients seeking lower lid blepharoplasty, usually age group between 45 to 60 years of age, the transcutaneous blepharoplasty with arcus marginalis release, fat repositioning, and orbicularis oculi muscle suspension provide very good cosmetic result with minimum risk. It is, however, time consuming. So, this procedure is very good for the old age patient, that is transcutaneous blepharoplasty. Transconjunctival blepharoplasty is ideal for the younger patient with mild or moderate eyelid fat herniation and there is no excess skin on the eyelid. It is also suited for patients with thyroid eye disease and can be combined with orbital decompression procedure. Complication of blepharoplasty. Blindness is first complication because of orbital hematoma. Bradycardia because of extraocular muscle reflex, dry eye, lower eyelid retraction, eyelid ectropion, rounding of lateral canthus, hollowing of eyelids, epiphora, leg of thalmos, asymmetric upper eyelid crease, diplopia, blepharoptosis, chemosis, corneal abrasion or ulceration, injury to branches of facial nerve, sensory loss in distribution of intraorbital or zygomatic nerve, irregular lower eyelid lumps, and fat necrosis. These are the common complications of the blepharoplasty.